well-known practicing endocrinologist at Ahmedabad. He is an honorary associate professor and head of the department endocrinology, SVP Hospital, Ahmedabad. He trained in France. He participated in many national and international conferences and presented many papers. He involved in as a principal investigator in various clinical trials. He is a co-author of chapter of RSSDA textbook of diabetes 2004 third edition. He has interesting thing about the Tiven Marwah. He is writing article every Wednesday for Divya Bhaskar newspaper, and he has written more than 300 articles till date. And interestingly, another things about the Dr. Tiven Bhai is he is the author of two books written in Gujarati, and the name is Diabetes ni Kadvi Mithi Vato, and second one is Gaur, Khan, Mud, and Saccharin, Ketla Mitha ne Ketla Kadwa. Really interesting about this. He involved in many national and international charity organization, and he received many awards, including AMA and the awards from Gujarat government. With this, I invite Dr. Tiven Marwah sir for his presentation, and the topic is beta cell preservation, a promise of DPP4 inhibitors. Over to Dr. Tiven Bhai.
Uh, Thank you, Dr. Dhiren for such a lovely, kind introduction. And I'm extremely thankful to DIACON and particularly Dr. Bansi Sabu for inviting me to deliver this talk and participate in this conference. Dr. Bansi, as you know, that he has done remarkable things over a decade or so to enhance the knowledge and information among physicians, internists, endocrinologists, and which has been immensely benefited to the patients at large and society. So his contribution is really exemplary, and I acknowledge it and I appreciate it. The topic given to me is beta cell preservation, how we can achieve through different molecules. I know this is a very, very important topic, and as we know that diabetes is a product of two major important defects. One is insulin deficiency and another is insulin resistance. And in a given type 2 diabetic patient, these both entities exist together. It's a combination which gives rise to hyperglycemia and leads to diabetes. And the importance of beta cell dysfunction is enormous, and it is particularly important in our country. Indians are more susceptible to have beta cell dysfunction. This is very well-known hypothetical slide, which has been presented several times that as the duration of diabetes increases, beta cell function declines, and this leads to increased A1C, and we have to adapt to the decline in beta cell dysfunction and increase in A1C and modify treatment of the patient so as to control his diabetes and to bring A1C below 7%. And over years, there is a greater decline in beta cell dysfunction, and this leads to more and more hyperglycemia, which we need to correct. And as the beta cell dysfunction is higher, as it has been shown in this classical study, the beta decline study, the C-peptide secretion or insulin secretion, when it declines, the chances of A1C becomes higher. So in this study, which is shown through proinsulin-insulin ratio, which is a marker of beta cell dysfunction, when there is an increase in PII ratio, that is proinsulin-insulin ratio, there are higher chances of patient getting A1C more than 7%. In the other way, when beta cell function is intact, chances to get A1C less than 7% is higher. So beta cell dysfunction is very, very vital and important to control diabetes and to keep the target of A1C less than 7%. Higher degree of beta cell dysfunction is associated with poorer glucose control, which is quite logical, and this has been reflected through higher pro-insulin-insulin ratio. What are the other clinical predictors which can tell us about the beta cell dysfunctions? In this study, it was mentioned that BMI, high CRP, dyslipidemia, they were clearly correlated to decline in beta cell dysfunction. Now the question arises how we can measure beta cell function. this can be extremely useful clinically and also in experiments to understand the newer molecules and how to use molecules to treat our n number of diabetic patients. So there are several methods. We cannot measure directly beta cells. It will be a very challenging thing, but we can measure beta cell functions in indirect ways. And one of the best ways is to HOMA. We can assess both insulin resistance and beta index, which tells us about the insulin resistance level and also the insulin secretory capacity. And as you see in the slide, uh, as you move from on the left side, it is on insulin resistance, and on the right side, it is insulin secretion. As you move from normal to IFG to IGT to combination of IFG and IGT, which is diabetes, the insulin resistance increases. And on the other side, right side, as you move from normal to frank diabetes, there is a decline in beta cell function and it leads to increase in hyperglycemia and diabetes. There is another way how we can assess insulin resistance and beta cell mass, that is disposition index. What is disposition index? It's a true assessment of beta cell function and which can be assessed by insulin sensitivity and insulin secretion. The product of insulin sensitivity and insulin secretion is called the disposition index, and it is directly related to insulin secretion. And as you see on the right side of the column, as you move from normal glucose tolerance to IFG to diabetes, there is a decline in disposition index, which indirectly mentions that there is reduced beta cell mass. Of course, this is not structural representation. This is the functional representation of beta cell mass. And as you move from normal glucose tolerance to IFG to diabetes, there is a reduction in beta cell mass function, and it leads to increased diabetes. Now, we need to control diabetes, and to control diabetes, the most important thing is to preserve beta cell functions. And this is very important in Indian patients because Indian patients are more susceptible to beta cell dysfunction. Sorry. Indian patients are more susceptible to beta cell dysfunction, and we are having both combination of insulin resistance and insulin dysfunction, beta cell dysfunction, and Indian patients are more susceptible to reduction in beta cell function. There have been many studies which have shown that as in Indians, we are more likely to develop beta cell decline, and this happens in the early stage. The beta cell decline is very early in Indian type 2 diabetic patient, and that's the reason in Indian patient we need to have the strategy which can preserve beta cell function, and it should address these problems right from the beginning. There are several ways through which we can preserve beta cell function, and for that we need to understand what are the issues which can hamper beta cell functions. Autoimmunity, inflammation, islet amyloid, then insulin resistance, hyperglycemia, glucotoxicity, lipotoxicity. All these parameters, they lead to decline in beta cell functions. So if we want to improve beta cell functions and improve beta cell working and preserve insulin secretion, we need to address all these issues. Now, what are the mechanisms or molecules which are at our disposition, which we can use to prevent beta cell declines? Well, we are having statins, which can reduce inflammation. We are having glitazone, which can reduce islet amyloid, and we are having incretin-based therapy, which can improve hyperglycemia and also preserve beta cell function. The molecules which are already known to have impact on beta cell functions are mainly insulin, glitazones, and incretin-based therapy. What they do, and it has been found from studies through glitazones and incretins that they reduce beta cell apoptosis, they promote beta cell proliferation, and through this they increase insulin synthesis and secretion. and they improve insulin secretion pattern. So at least for these two molecules, glitazones and DP4 inhibitor, it has been shown that they had impact on beta cell function, and through this they can improve the survival of beta cell and also preserve beta cell functions and improve insulin secretion in the long term. Now let's focus on gliptins. What are their roles in preserving beta cell function and insulin resistance? So gliptins are known to have impact on beta cell functions and also some impact on insulin resistance. So this study, which is a sort of summary of the impact of DP4 inhibitors on beta cells, what they have shown, DP4 inhibitors as monotherapy, it significantly improves HOMA beta. As an add-on therapy, also they improve insulin secretion. There is no significant impact on insulin resistance directly, but there is indirect effect. And when they do this job as monotherapy, they improve hyperglycemia, and this is comparable to metformin, sulfonylureas, and glitazones. As an add-on therapy, they are beneficial and they work in a synergistic combination with metformin, sulfonylurea, insulin, and all other drugs. So these drugs, they are having impact on both HOMA beta and some impact on insulin resistance. Now let's focus on vildagliptin because there are lots of evidence on vildagliptin of its therapeutic potential and benefits. What do the clinical trials show? Clinical trials have shown that vildagliptin, either 50 or 100 milligram OD, they reduce A1C levels, they are safe and well tolerated, and they improve beta cell function. This is a busy slide, but in nutshell, it has shown that there is improvement in beta cell function, there is no significant improvement in insulin resistance, but there is improvement in hyperglycemia. Why they use 100 milligram OD? Because this study was to assess post-breakfast meal impact, and breakfast and its impact is seen only in 4 hours, and that's the reason why 50 or 100 milligram OD was used to assess the impact. And both were equivalent because vildagliptin can suppress DP4 enzyme even if it is given in the dose of 10 microgram for at least 4 hours. Now there is a comparison of metformin versus vildagliptin as a monotherapy in Asian Indians with type 2 diabetes. So what is the impact on different parameters? Of course, insulin resistance is improved better with metformin, but if we see the direct total effect, the A1C reduction was similar, postprandial reduction was better with vildagliptin, and the median duration of monotherapy requirement was almost equivalent in both metformin and vildagliptin. But there are distinct advantages of vildagliptin alone or combination, which we are going to see in the subsequent slide. Vildagliptin improved beta cell functions and insulin sensitivity in patients with impaired fasting glucose. There are almost half the number of patients who are pre-diabetic as there are diabetic. And these patients, 33% of them, they are likely to develop diabetes. So what is the impact of vildagliptin on pre-diabetic patients? So this study which was done to assess the impact of vildagliptin on beta cell functions, and it clearly showed that vildagliptin improved ARG, that is acute insulin response to glucose, and insulin sensitivity index. And when you withdraw this medicine, there is a washout, and there is the benefit you are seeing is no more. So there is definite improvement in beta cell function, and this is visible even after 8 weeks, which is shown in pre-diabetic patients with IFG. Now, what is this impact on diabetic patients? They also improve beta cell function and insulin sensitivity. In this study, it was shown that long-term vildagliptin treatment can increase insulin sensitivity, and there is other marker which is called adaptation index. It was also shown to improve when you give vildagliptin in comparison to other molecules. So pioglitazone was found to improve further the beta cell function when you give along with vildagliptin. This is another clinical study which has shown what is the impact of 3 months treatment of vildagliptin, 50 to 100 milligram per day on modulating insulin resistance and beta cell function, and of course its impact on hyperglycemia. So this study showed that there is a reduction of A1C from 11 to 8.7, almost 2.3, 2.4% reduction. There was reduction in fasting hyperglycemia. There is also some improvement in insulin resistance, which might be indirect effect. And very, very importantly, there was very good improvement in beta cell function, almost 70% just after 3 months of treatment of vildagliptin. So vildagliptin was found to have impact on beta cell function, indirect impact on insulin resistance, and then in nutshell, there was an impact on HbA1c reduction was almost 2.3%. Now, what is the impact of vildagliptin on beta cell secretory capacity? As I was telling, that there are many, many ways to assess beta cell functions, and there are many studies which were done either clinically or in the experimental way, and they have directly or indirectly shown the importance and impact of vildagliptin on beta cells. So another study which has shown that in the black bar, when patients are on vildagliptin, there is increased AIR, that is acute insulin response, and when patients are off the drug, this effect goes away. So effects were not sustained after 12 weeks washout period. That means patient would need a continuation of this medication to get the benefit on insulin secretion, as well as some indirect impact on insulin sensitivity. So again, in this study, it was shown that when you give vildagliptin for a year, there is a increase in beta cell function just after 12 weeks, which is sustained for a year, 1 year. And there is also improvement in insulin resistance, which is also sustained for a year. This another study, it has also shown that when you add vildagliptin on top of metformin, even after a year, there is improvement in insulin secretion. And of course, this combination would have a great impact on insulin resistance as well. So the adaptation index, which is an indirect marker of secretion as well as insulin resistance, there is improvement, there is reduction, and you get the complementary benefit of using this combination. Now, this slide, it shows even more clearly the advantage of vildagliptin metformin combination. And as you can see that vilda 50 milligram OD, there was an increase in beta cell function, and vilda 50 twice daily, there is slightly more increase. But if you give metformin, there is no increase, and the difference between metformin alone versus vildagliptin alone, vilda plus metformin, there was a almost 5-fold increase in beta cell function when it was added to metformin. The combination of metformin plus vildagliptin, it gives benefit on two events. One on insulin secretion, which is almost 5-fold than if you use only metformin, and there is also improvement in adaptation index, insulin resistance, etc. The recent ESD 2020 showed very nicely the effect of beta cell function in newly diagnosed type 2 diabetic patients after treatment of vildagliptin and metformin. This very famous VERIFY study, it showed that after 1 year of early combination, there is improvement in beta cell function, and this improvement is much more significant than if you use monotherapy. So there is no doubt that metformin is not working on beta cell function, but this metformin plus vildagliptin combination, because of vildagliptin, there is remarkable improvement in beta cell function, and this was seen after the end of first period. And the conclusion was the early combination treatment with vilda and metformin in patients with newly diagnosed type 2 diabetic patients, it does show improvement in beta cell function and compared with monotherapy, which is metformin. So early use of both vildagliptin and metformin give remarkable impact on beta cell function, which is the need for our Indian diabetic patients, because Indian diabetic patients are more susceptible to early beta cell function loss. Now, what is the impact of gliptin on overall islet cell function? As you know that islets contain alpha cell, beta cell, gamma and delta cells, and they all have some impact on pathophysiology of diabetes. And we can't forget the importance of glucagon and alpha cells, and we need to see what does vildagliptin does on alpha cells. And in this study, it was shown that treatment with vildagliptin, it resulted in both reduction of fasting and postprandial glucose levels. There was also reduction in glucagon levels because vildagliptin suppresses alpha cells, and there is reduction in glucagon levels, which leads to improvement in hyperglycemia. And there was no effect on absolute insulin secretory rate. So vildagliptin has got impact on both beta cells and alpha cells, and because of its impact on both alpha and beta cells, and also which is glucose dependent, it's a very smart molecule to manage diabetes and without producing hypoglycemia and without producing major excursions. So vildagliptin has got ability to impact both alpha and beta cells. Both they can sense and respond to hypoglycemia when vildagliptin is given to the patient. So this is very, very important aspect of vildagliptin. When you give vildagliptin to diabetic patient, there is suppression of plasma glucagon levels during hyperglycemia, and very, very interestingly, when there is hypoglycemia, there is increased plasma glucagon. So there is not only glucagon suppression is removed, but there is in fact increase in glucagon, which can eventually improve blood sugar level and prevent person to develop hypoglycemia. And so there is a significant increase in glucagon during hypoglycemia, as well as the suppression of insulin secretion. So the beauty and smartness of this molecule is that it suppresses plasma glucagon levels during hyperglycemia when it is very much needed. It increases glucagon level during hypoglycemia when it is very much needed, and also it stops insulin secretion during hypoglycemia. So it is both hypoglycemia friendly and anti-diabetic drugs, and it lowers postprandial glucose concentration by stimulating insulin secretion and suppressing glucagon secretions. Again, in the blood bars, there is increase in insulin secretion, and also on the right side, there is improvement in disposition indexes. So, vildagliptin, there are other ways to understand the responsibility index and total disposition index. They get ameliorated by using vildagliptin. Now, what is the difference between SGLT2 inhibitors and vildagliptin or DP4 inhibitors on insulin and glucagon? On right top panel, you can see that when you give SGLT2 inhibitors, they are not able to suppress glucagon, whereas vildagliptin, they do suppress glucagon. So in case when you use SGLT2 inhibitor, there is hyperglucagonemia, and which can worsen hyperglycemia in some patients. And there is 15% lowering of both fasting and postprandial glucagon levels as compared to SGLT2 inhibition with dapagliflozin. Dr. Mukherjee very nicely and elegantly highlighted the use of SGLT2 inhibitors and combination. So the disadvantage of SGLT2 inhibitor can be offset by combining DP4 inhibitor, which will eventually suppress the increased glucagon level, which is achieved through SGLT2 inhibitors. So we are having different molecules we need to use in a correct way to benefit our thousands of diabetic patients. And we need to keep these things in mind, that there are multiple pathology to produce hyperglycemia, and we need to use the molecule in a right way to address the right pathology to correct hyperglycemia. And these are the signals which can be useful to choose the right molecules. We need to have medicine which should improve insulin resistance, improve beta cell function, lipid health, glucagon secretion, and eventually A1C. So DP4 inhibitor has got impact on multiple such mechanisms, and if we combine with metformin, it will address almost 7 out of the 8 ominous octet, and it can reduce hyperglycemia, and it can benefit multiple of our type 2 diabetic patients. So to summarize my talk, beta cell dysfunction and insulin resistance are the two most critical determinants of type 2 diabetes. And in Indian patients, they are more susceptible to beta cell dysfunctions. and we need to choose the molecules which can address these issues right from the beginning. And we have seen that when there is high insulin resistance and beta cell dysfunction, this will lead to hyperglycemia and diabetes. And in all these experimental clinical studies, they have shown that DPP4 inhibitors, they address at least, if not seven, four major pathways of the amino acid octet. And when you combine with metformin, they address 7 out of 8 parameters of type 2 DM amino acid octet, and they can be a very, very useful combination to treat multiple of our type 2 diabetic patients. Vildagliptin per se improves beta cell function and insulin sensitivity indirectly in patients with impaired fasting glucose, those who are having pre-diabetes. It can be a good molecule. And lastly, vildagliptin has got very favorable effects and capacity in modulating insulin resistance and beta cell functions, and they can be a great therapeutic armamentarium to treat many of our type 2 diabetic patients right from the beginning and also in the middle stage of the diabetes. Thank you very much for your very patient hearing. And if there are questions, comments, we can share together. And once again, Dr. Bansi Sabu, thank you for inviting me to this important conference.